Hello, everyone. This is Dr. Carmen Pugliafito, and I'm pleased to have here today Dr. Dante Pieramici, who is a partner at California Retina Consultants, co-director of the California Retina Research Foundation, and assistant clinical professor of ophthalmology at the Doheny Eye Institute of UCLA. Dante, welcome to Retina Synthesis.
Carmen, glad to be here. Look forward to our conversation.
So today we're going to be talking about a company and a drug that proposes a different treatment algorithm for treating wet AMD. Can you discuss their treatment algorithm and the agent?
I'd be happy to. The company's Ophthea. It's a company that comes out of Australia, and their drug is OPT-302. It's a trap protein molecule that actually traps VEGF C and D, unlike, say, Eylea, which traps A and B. It traps the two other molecules. You know, you're exactly right, Carmen. What they're looking for here is not just another Me Too anti-VEGF, but they're really looking to block a slightly different VEGF pathway. That's the VEGF C and D. And, you know, preliminary work would show that, and we can go into more detail about this, but in their phase 2 clinical trials, they demonstrated that when you block VEGF C and D in addition, so in combination with a VEGF AB block, that you get actually better visual acuity outcomes and better anatomical outcomes. So what they're proposing actually is a combination approach, because we've seen that in preclinical work and in patients, when you just block VEGF A and B, say with Eylea, or VEGF A with Lucentis, there's actually an upregulation of CD. It's an escape mechanism. And this may in part explain why some patients don't do as well as we would like, why the anatomical results aren't as good, and patients can not improve as much in vision and not have a dry retina in some cases. So by blocking all these, A, B, C, and D, we may get a better result, both from a visual standpoint as well as an anatomical standpoint. And this would change our algorithm. We'd probably start treating patients with our typical medications. And if they don't respond well, we might go and switch over to adding this in combination to see if we can get a better result in our patients. So yeah, different approach. They're looking in their clinical trials. They're not looking to increase durability. That's what everybody's doing right now, because, you know, the bar is pretty high with VEGF A and B blockage. So now, instead, most people are saying, well, we can't do better than that. But what we're going to try to do is less treatment, make the treatment more durable. And this is what we see with, you know, gene therapy, the port delivery system, protein kinase inhibitors. But Ophthea, with their drug, OPT-302, what they're going to investigate is actually superior results using this combination approach, not a durability play, but a superiority play with both vision and anatomy.
So you recently presented the phase 2 results at the Clinical Trials Summit. Can you tell us a little bit about the study design and the results?
Sure. I mean, it was actually a relatively large study for a phase 2 trial. They had 366 patients in this trial, and there were 3 arms in this phase 3 trial. All arms got ranibizumab every month. So that was the anti-VEGF A suppressor. In one of the arms, there was a combination placebo injection. And then in the other 2 arms, they got combination with OPT-302 at 2 different dosages. And the OPT-302 was given every 4 weeks as well. So it was a double injection every 4 weeks. And this was a 6-month trial. These were treatment naive patients with wet AMD. And so it was a relatively large study. And what they found in this trial, and again, there was 2 different dosages that were looked at of the OPT-302. They had the high dose, the 2 milligram dose, and then they had the lower dose, which was the 0.5 milligram dose. And what they found was that there were superior visual results in the high dose group compared to monthly ranibizumab monotherapy. And the low dose group did about the same as the monthly ranibizumab therapy. So it's the 2 milligram dose that actually had an improvement that was highly statistical significant at 6 months of about 3.5 letters. In addition, this trial demonstrated that there were improved or superior anatomical outcomes with retinas that were dry of subretinal and interretinal fluid at 6 months in the high-dose combination treatment compared to monotherapy or the low-dose combination treatment group. Interestingly, they also looked at a sub-analysis in the patients that typically tend to be some of the most difficult to treat. Those are with minimally classic or occult choroid neovascular lesions. And in this group, they actually found that the OPT high-dose combination therapy did even better compared to monotherapy. And there was almost a 6-letter difference. And this, again, was highly statistically significant at 6 months.
And what group was that again?
This was patients that had minimally classic or occult choroid neovascularization. So they eliminated the type 2 lesions, the classic C and D lesions, the ones that typically respond pretty well to anti-VEGF therapy, and looked at the more difficult to treat patient groups. And they found an even more robust difference between their OPT combination with ranibizumab compared to monotherapy ranibizumab, with about a 6-letter difference at 6 months. And again, highly statistically significant. So superior results in this typically harder to treat group that don't respond quite as well with OPT combination.
Well, the results are impressive because they set a very high bar. Monthly ranibizumab is more definitive treatment than we typically do in real world ophthalmology. So if they got 3.5 letters against that, that's impressive.
Yeah, and 6 letters, I said, nearly 6 letters in the the more difficult to treat patients. So yeah, I think it's pretty exciting. And like I said, they're really the only people right now really doing a superiority study. Most folks are doing non-inferiority studies and looking at increased durability, like we saw with the Vabysmo trial or the Eylea high-dose trial. They're looking really for better durability, but not superior results. Because as you mentioned, the bar is pretty darn high with anti-VEGF-A suppression alone.
What's the mechanics of the delivery? Same day, double injections?
Yeah, it's an intravitreal injection. You could do it the same day. In the studies, typically they'd give one injection and then you'd wait 30 minutes for the pressure to come down and then go ahead and give the second injection. Patients tolerate it pretty well. You don't really need to do a paracentesis if you wait, but you can do that. I think that, the future for this drug probably would be a co-formulation. The ranibizumab agents are now in biosimilar formation. So you could imagine them partnering if they get positive results with their trials with a biosimilar company and making a co-formulation. So it then could be one single injection perhaps in the future.
Yeah. So what did the OCT show? Were the OCTs drier in the combination group?
Yeah, the anatomical results, like I said, really sort of paralleled the visual results as well. The high dose group really showed that the presence of subretinal fluid was reduced in the patients that had the combination compared to the monotherapy group at 6 months. This is both true for intraretinal fluid as well as subretinal fluid. And they looked at fluorescein angiographic characteristics too, like lesion size at 6 months and area of C and D at 6 months. And this was also more reduced in the combination group compared to the monotherapy ranibizumab group. So it seems to be, this visual improvement seems to be somewhat at least correlated with anatomical improvements.
So have they started their phase 3 trial yet?
Yeah, they've got 2 very large trials going on. They're called the Shore and the Coast trial. Each of these trials is going to recruit approximately 1,000 patients. So they're going to have 2,000 patients in these 2 trials. And in the trials, there'll be 3 arms. In the Shore trial, the comparator will be monthly ranibizumab, and in the Coast trial, the comparison will be loading with aflibercept 3 and then every other month aflibercept, because they really want to offer, if it works, they want to have it compared to both. The treatment arms will be, the combination arms will be ranibizumab every month in the Shore trial, with OPT monthly, and then they're going to have an extended OPT group, which will be every 6 weeks. So it'll be OPT every 6 weeks with monthly ranibizumab, and then OPT every month with monthly ranibizumab compared to monthly ranibizumab. And the other trial will be, each group will get aflibercept loading times 3, and then every other month. And then again, the monthly OPT 302, and then every 6 weeks. So they want to see if you can get maybe, some of the patients may just be able to go every 6 weeks with getting a dual therapy. So they're going to try a little bit of an extended approach to it as well. And this trial, this trial is already recruiting patients. They're looking again at naive patients.
Really?
Yeah, and they're going to look at all comers. I mean, not just minimally classic and occult, but also classic lesions. They're going to have a hierarchical evaluation of this. So they're first going to look at the group, the best responder group, which is going to be these minimally classic occult group. And if they pass, statistical significance there, a superiority study is what this is. They'll then look at all the lesions together to see if that also meets superiority. So, this is going to be done in the United States and around the world. It's already recruiting. They're hoping to be done recruiting, I think, by the end of 2023. So sometime near the end of this year, beginning of next year. The problem with recruiting this makes it a little bit difficult is that since it's a superiority study, they can't have patients included that have good visual acuity because there would be a ceiling effect. So the patients have to have vision between 20/60 and 23/20. So you know how it is when a patient comes in for a study and they're 20/50 or 20/60 and you refract them, then they're 20/30 or 20/25. So it's been a little slower to recruit just because of this requirement to have, a non-ceiling effect on a lot of their patients. So they have to have patients that can improve in vision. And it's made it a little bit more difficult. But the primary outcome will be at 1 year, and it'll be, the mean change in best corrected visual acuity compared between the groups. But they're going to continue to study then for another year at that point.
Do we know what the FDA will want?
I don't know. It's complicated. I know the FDA basically recently changed their recommendations, that they really wanted to see more like a 15-letter improvement for superiority in some of these trials. So it's good. That's their recommendations. They've had conversations with the FDA, and I think that if they can get similar results to what they got in the phase 2 trial with statistical significance in these 6 or 3.5 letter improvements, it's highly statistical significant. Hopefully that'll be enough because, like you said, the algorithms, this would add to the algorithm. This would give us another tool in our armamentarium to treat some of these difficult patients and patients that aren't responding 100%. And it may be different than just switching to another anti-VEGF A or B inhibitor. This would be, something completely different.
Well, the results are promising, and this, as you pointed out, a unique agent looking at superiority. And I think the FDA won't make them go 15 letters.
Yeah, I don't think so either.
No.
It seems like a pretty darn high bar.
That's impossible.
Right.
Well, hey, Dante,
Yeah.
this was a great discussion.
Yeah.
Thanks
My
a lot
pleasure.
for coming on Retina Synthesis.
Oh, anytime, Carmen. A lot of fun.
Yeah.
Be well.